So what about to meet to him and sit beside and take photos with him? Actually, he's a great teacher, great inventor, and this is during one of his famous January online courses for congenital deformity. And see how he is so keen to teach and to give every secret about the topic. Also, in conferences, Dr. Bell is considered to be the keynote, the smart guy who everyone wants to say hi to him. Even if you can see in this photo, the speaker is presenting and he's doing revising some work or publications or revising his topics. He always teach and stay on his laptop, so he don't have time maybe for others except teaching and learning. And this is during one of the American Academy of Orthopedic Surgery courses, and he is always keen to be there every year. Not only this, he is always creator and innovation, because this is his Peli software hexaboard, where what he was invented, and I was so lucky to meet him at the beginning of this era and take a photo with him. This was in Charleston. And socially, he has very, very lovely spouse, and we could take dinner together with Professor Herzenberg. So he not only teacher or giving secrets of medicine, he's enjoying his life with others, with his wife, with everyone. So I'm very thankful. Let me go inside his great home. It is not a home. It is like a full apartment of 4 or 5 floors. It is in front of the Atlantic Ocean directly. So touching the wood, I hope to visit him again and again. And this is inside his home. And you can see here, this is from our side. This is the Atlantic Ocean, and this is his home from the back, and this is how he's speaking and talking socially to everyone visiting him. So if Jose Mourinho, the Portuguese guy, is a special one in football game and in soccer game, I can say definitely without doubt, Professor Dolobelli is the special one in the field of pediatric and limb deformity and reconstruction and joint preserving surgery. So he is the special one. Definitely, Bailey Institute is not just an institute, it is a complete kingdom under his name, under his guidance, under his cooperation, and under his advisorship. And anyone wants to learn and get more and more, he must visit him and be in a relation with Professor Bailey. So definitely, whenever you go there, you deserve the best care at Bailey Institute. So Al-Azhar University as a whole, orthopedic surgery department especially, we are all welcoming today Professor Dolor Bailey, who are going to speak to us about this interesting topic. And we hope that he can join us again and again in coming webinars. Thank you, Professor.
Thank you very much. Can you hear me?
Sure.
So before I share my screen, well, first of all, I know it's late where you are. Here it's only 4 in the afternoon. I'm actually looking outside. I will turn my screen so you can see the beautiful view that I'm looking at. So that is outdoors with the palm trees, and that's the island of Palm Beach, and that's the Intercoastal in Florida. It's a beautiful place. And so it's a pleasure to be here with you. And before I get started, first of all, I want to thank Ahmed Hamouda for organizing this. He's visited us several times. He's been a great fan. He visited me now for many years, and it's always a pleasure to teach you, and you're a wonderful student, and you're a wonderful representative, and I know you do great work in Egypt, and I appreciate you organizing all of this. I think that while there are many very negative things that have come because of coronavirus, maybe one of the, there's always what I say, a silver lining in every cloud. And I think this has taught us to, to do many things differently. And we've learned to work from home. We've learned to work, on telemedicine. I'm sure all of you are doing that. I do a lot of my work now on telemedicine, and especially with my practice, which is a practice coming now from 95 countries and, all 50 states. I can provide, very good consultations online. It's a little challenging to examine the patient, which we cannot do hands-on, but still, it's remarkable what we can do. And I think the other great thing that has come from it is, before, when you wanted to hear a speaker live, I mean, you have to go to a conference, and now so many of us are being involved in these webinars. And I said to my family, listen, I got to go. I'm headed to Egypt tonight. I'll be there for a couple hours, but I'll be back. And you know what? I won't even be jet lagged when I get back from Egypt tonight. So a few weeks ago, I was in India for a few times, and I went to Colombia. And so it's amazing. I go all over the world and I'm not even exhausted. And it's really the new world. I think this is fantastic. I think it has made the world a smaller place, and it's brought us closer together. This common enemy that we're fighting, the coronavirus, has brought us all closer together and made us realize that we have much more in common than we have different. It helps us put aside our differences and focus on what we have in common. Of course, tonight, what we have in common is our interest in learning, our interest in disease, our interest in helping patients, and we'll focus on that. Before I do that, I'm looking at the 170 participants. By the way, you have a long way to go. When I spoke in India, they had 4,000. So I expect a few more next time we do this. But it's interesting.
Next time will be more and with the Zoom, because this application is different.
It's okay. We worked through the technical challenges tonight.
Okay.
But thank you. I'm looking through the names, and I see many of my former fellows. I see many friends, many colleagues, and so on. And, I cannot, I don't have time to acknowledge all of them. I'm just going to acknowledge a few people that I see on the list. First of all, we're speaking about congenital pseudoarthrosis, and one of the earliest research projects that we did when I was still in Baltimore on congenital pseudoarthrosis became the PhD thesis of an Egyptian orthopedic surgeon, Mahmoud al-Wasasi. And in fact, we have a classification we put together on this that's been published. And I see, Mahmoud, you're online. So I wanted to acknowledge you, and I appreciate you coming on. And I know you're a very experienced surgeon in this field. I also see my very long-time dear friend who's been my host when I've come to Egypt, Yasser al-Batrawi. And Yasser, I wanted to say hello to you and your wife, and thank you for logging on tonight. I also see he was a very young man back then. I guess we've all gotten older. Mahmoud Falafel, who took me to his small little village, and we traveled to really one of the most interesting experiences I had in Egypt. Not going to the big city, but going to the small little towns. And I just saw regular life, even a funeral and other things that I would never have seen. So I see you there, and I remember your beautiful hospitality for me. So I just wanted to say hello. And lastly, and I apologize. I mean, I have many former fellows from Egypt, and I see several others, and I'm not going to acknowledge all of them. I have a lot of them, and we are, by the way, open to all international visitors, and we enjoy having our Egyptian colleagues, and I will continue, of course, to provide international fellowships to Egyptian and other countries who apply. It's an unfunded fellowship, but we will arrange for you to have a great experience when you do come, and also if you come to our courses. And we run, especially in January, a congenital limb deformity course. I don't know how it will be this year, with COVID and what we might do different, but hopefully some of you will come, and you're all welcome. But lastly, I'm honored to see my dear friend for many years, Michael Weber, who lives in the UAE in Dubai. And Michael, a warm hello to you. You've now surprised me by showing up at one in-person lecture in Dubai and one online lecture here. So it's always a pleasure to have you in attendance. I've known Michael since when he was a medical student. So that shows you how old I am. So, all right. Well, let me share my screen, and I like...
Dr. Billy, can Professor Hussein, the Dean of the Faculty, just entered. Can he say hello before you start?
Of course, of course.
Yeah, just a second. Dr. Khairi, unlock Dr. Hussein Abou Lghid. Dr. Khairi? Dr. Khairi, can you hear me? Mons Abdelaziz. Okay, so I think you can go ahead.
Okay.
At the end.
We can do it later, yes.
Yeah.
So, I've been involved working in congenital pseudoarthrosis since my first treatments were in 1987 when I was still in Toronto. And I treated my first 4 cases in Toronto before I moved to Baltimore. And those 4 plus a few others formed the first 16 cases that I published. I think in 1992 was the first article. And since 92, I have published, I think, 7 articles and book chapters on congenital pseudoarthrosis. But the most important is the ones that I published, the last 3 that I published, and most importantly, the last one, on a technique that I'm going to speak to you tonight. And in congenital pseudoarthrosis, I've had a really good success rate. I've never not gotten one to heal. So you could say I've always had a 100% union rate. But, when my first 16 that I followed them up, and initially I had all union, and then eventually I started getting refractures. They were all treated with the Lazarov technique. And in the end, I think Mahmoud al-Rassasi reviewed them, and we ended up with 73% refracture rate. This was very disappointing. And so this has led us to make modifications to the technique, which evolved. But it wasn't until 2007 that I made a really revolutionary modification that has changed everything. And we're going to talk about that, and that's called the cross-union method. The Paley cross-union protocol is how it's called in the literature. Now I'm going to open up my, hopefully, yeah, I've got a problem. I opened in the wrong. I'm gonna have to log on. Give me 1 second. I will be right back. Okay. I'm gonna have to log off and log on. Sorry about that. problem I had, but I think I'm now good. And we will do the screen share. Okay.
Let me just tell everyone that this session is live on the Facebook page of the department and also on the YouTube channel.
Are you able to see my presentation?
No.
You do not see my presentation? Can you see my slideshow? Are you able to see the slideshow? Hello? I don't hear anybody.
Yes, I can see it. We can see it.
Okay, I'm going to do it onto slide view. How's that? You can see it okay?
Yes.
Okay, so we're going to start. So I'm going to talk about congenital arthrosis, and we are achieving now 100% union, no refractures. And this is called the cross-union protocol. You know, CPT is a pathology that only recently were pathologic problems at the cellular level. And we know for years, since beginning of 1900s, when Cordovilla commented that this was a periosteal disease. And we know that there's this transformation of the periosteum into this fibrous hematoma surrounding the bone. When you look at it, in some cases, it's so thick, it looks like it's strangulating the bone, and the bone ends become sclerotic and atrophic, and the medullary canal disappears. We have, as I said, there's been people who've talked about this being a periosteal disease for a long time. Most people credit McKelveny in 1949, but I found a reference all the way to Cordovilla in 1905. Dr. Weber and his group in Germany commented on this, and they found that on the microscopic level, the cells were the perivascular cells were surrounding the blood vessels in a way almost like Schwann cells, very reminiscent, since neurofibromatosis is very commonly associated with this condition. Cho showed that there are more osteoclasts and that there is a higher osteoclastic activity. This is very relevant and very important in our treatment and our decision-making. And Schneider showed that there's a positive synergistic responses to biphosphonates and bone morphogenic protein. And this latter finding, which really, I think, a great deal of the work was from David Little's lab in Australia, showing that NF mice have a deficiency of production of bone morphogenic protein. And they also have a hyperosteoclastic activity. And therefore, this led to the suggestion that you should not only try and inhibit osteoclasis, but you should try and enhance bone formation by adding bone morphogenic protein, since these patients are deficient in that. And some of this has been corroborated now in human bone and not just in mice. Now, that's that's basically almost all we know at the pathologic level. That's a summary of what we know. I'm sure we're going to learn more. When I started in 87 treating this, we knew none of this except that there was a hamartoma. It wasn't even accepted that it was a periosteal disease. Now, the next thing I want to jump to is straight to the clinical. So we always talk about what our goals of treatment are, and everyone jumps immediately to union. And of course, union is the most important thing. We want to achieve union. But really, we should be saying two things. We don't just want to obtain union, but we want to obtain union without recurrent fracture. And refracture is a problem. So a union that is followed by a refracture a few months later is really not a success. So we have redefined success as union rate times 1 minus the refracture rate. 1 minus refracture rate, okay, is the ones that didn't break. So if you got 100% union rate, but 80% refractured, 1 minus refracture is 20%. That's 0.2. So it's 0.2 times 1. Your success rate is only 0.2, 20%. So that is the strict definition that we are using for success probability. We did a meta-analysis of papers published between 1990 and 2018. And what we found in this meta-analysis is that the average union rate, and these were for different treatments, rotting, alizaroff treatment, alizaroff plus rotting, and free vascularized fibular graft. The average union rate was 72%, and the average refracture rate was 24%. But when you multiply each of these by each other, you get a number which is the success probability, and you can see the average success probability was only 50%. That means we're only in 50% of cases are we achieving union without refracture. There were two recent studies, both published in 2018. One was a meta-analysis by Kesereddy et al. And JPOB, and they found in a group of 401 patients that union rate was 75%, refracture was 35%, and the success probability, therefore, is 49%. And then Shaw et al. In the same year in JPOA published a multi-center study where they looked at 109 cases, and they had 102 of 109 heal, and the refracture 42.5%. So they had a 49.5% success rate. Now I want you to notice something. My meta-analysis gave 50%. These are both about 50%. And we have not been able to break this barrier of 50%. So when you look at a parent in the eye, and they ask you about how to treat their child's congenital pseudoarthrosis, by conventional means, don't quote them the union rate, quote them the success rate, that the success rate based on the literature is 50%. Now, I have to tell you, there's no operation that I do that has only a 50-50 chance of success. I mean, that's not very good. How many operations, if you treat SCFE, you put a screw in, it's almost 100% chance of success that, you're not going to get any further slip. So most things we treat have much higher success rates. But CPT, the best we've done in over 100 years is about 50% success rate. Now, I published a review and paper in Journal Children's Orthopedics 2019, and it's called Congenital Pseudoarthrosis of the Tibia, Biologic and Biomechanic Considerations to Achieve Union and Prevent Refracture. This is a very comprehensive review of the important things about CPT. I highly recommend you download this. It's an open access journal, it's free, and read this paper. And this is followed by a supplement. So if you look, there's a place at the end, it says supplemental material is available, and press that link. And when you press the link, you will get the technique with all the illustrations of how to do this. This is only in the online version, not in the paper version. Okay, so what is the Paley cross-union protocol and why does it work? So I'll start with the technique. And the technique is we give a pre-op zoledronic acid infusion. So zoledronic acid is the third generation biphosphonate. As you know, it inhibits osteoclasts. They cannot eat the bone. It breaks their teeth. So we give zoledronic acid, and it's protective for about 3 months. It needs to be given pre and not post-operatively. And the reason is so that it also gets into the bone graft, the cancellous bone that we're going to harvest as part of the treatment. If you give the zoledronic acid before surgery, then it will go into the bone graft and make the bone graft non-resorbable. You know, if you read the literature, people will describe how the bone graft disappears. It gets eaten up and resorbed. Well, if you pre-treat the patient with zoledronic acid, the bone graft cannot be resorbed. And this helps prevent recurrent osteoclasis also of the tibia and fibula bone, as well as of the bone graft. Now, we prefer to give this 2 weeks in advance. The reason for 2 weeks is that the zoledronic acid theoretically has a inhibitory effect on bone healing just right after it's given. And some people feel it might last for a week or two. So to avoid this bone inhibitory effect on osteoblasts and osteocytes, we give it 2 weeks in advance, so it's bound already to the bone and therefore has no impact on bone formation. After that, we go through a series of steps that I will illustrate, and then we end at the end with 3 months after the first zoledronic acid, or 3 months after surgery, giving a second zoledronic acid infusion. What's the purpose of the second one? The second one is given so that the zoledronic acid now goes into the new bone that was formed, the new callus. So that callus is also protected. So in total, the bone is protected maximally for 6 months, probably for a year from resorption. So this really gives the leg a chance. Now, I'd like to introduce you to a very simple classification that I published, and the CPT classification is based on what's broken. So type 1, the tibia and fibula are intact. Type 2, the fibula is broken, the tibia is intact. Type 3, the tibia is broken, the fibula is intact. Type 4, both bones are broken. Now, what about this A and B? A type is when the fibula is at station. Fibula has not migrated proximally. And B type is if the fibula migrates up. A type and type 4, fibula at station. B type, fibula migrates up. Type 4 also has a C type, which is when you have a bone defect. Typically, this is when you're dealing with a post-surgical case where someone has resected the bone. So that would be the C type. Okay, the incision is an anterolateral incision just over the anterior compartment. You can see the location here. We go through and then we incise the anterior compartment fascia, and we do an extensive fasciotomy. We then raise the anterior compartment muscle off of the tibia and the interosseous membrane. So that this cross-section is clear, this pink material is the fibrous hematoma. The reason you see 2 bones here, they're broken and overlap, it's like a cross-section right at this level. So the muscles are lifted off the anterior compartment, and the fibrous hematoma is left intact. Then on the medial side, There's a thin layer of fascia. We lift that up with the skin. That helps the skin circulation. And then we lift and get into the deep posterior compartment. We incise the deep posterior compartment along here, and then we retract back the deep posterior muscles off the tibia and fibula. Beware of the perineal vessels. And then once you've done that, you can remove the interosseous membrane. Finally, at this point, we can open the hamartoma. We make an anterior longitudinal incision, and then we make a circumferential incision at both ends. Where do you make the transverse incisions? This depends on where you want to achieve cross union. So you go as close to the ankle as you need to, and you remove the hamartoma in this region, and similarly up here. So this allows you to expose the tibia to the fibula bone, because we're going to do the same to the fibula. We're going to open its periosteum and remove it. So this is the fibrous hamartoma of the fibula. Now we can straighten out the bowing of the leg because the hamartoma is gone. If you have an intact tibia, and I'll show that later, we can actually cut the bone at this point in order to achieve the same thing. The bone ends are overlapped based on the tension of the soft tissues. So remember, the posterior soft tissues are tight, and so we had this anterolateral apex. Now we make it straight. We now cut the ends of the bone and square them off at the same level to each other. And we do this only for the tibia first. This is done with the saw. We then insert a wire and a cannulated drill into the bone. And this allows us to prepare for a rod in the tibia. We are going through the physis and epiphysis. We use the Fassier-Duval nail system. I understand that this may not be available. I know there are other systems. I know there's a telescopic rod, Turkish product that's available, probably cheaper. But maybe you don't have a telescopic rod, then you can just use a rush rod. But always antegrade. Please never go through the ankle. That just damages the ankle joint. Enter anteriorly like this, and do not go through the ankle joint. We custom size the female and the male parts of the telescopic rod, and then we insert the male part. It has a locking hole. Now, the normal Fassier-Duval has like a screw. If you order, it's called the LON or Paley modification, Pega Medical will send you this type, which is lockable. You then lock this usually with a 1.5 wire, and then the wire is cut and curled on the epiphysis. You then insert the female part, and the female part goes down the bone on top of the male part, and the two line up the bone like this. This is screwed into the epiphysis. Then we take a plate, and we have these very thin locking plates, not very stiff, very thin, very flexible. So you might have to find some of these thin, flexible plates. I'm sure they must have something. These are smaller than 1/3 tubular plates, to give you an idea. Even a 1/3 tubular is too big, and the screws are too big. The screws that we're using are probably, they vary between 2 millimeter and 2.7 millimeters. So we have three sizes, 2.4, and 2.7 millimeter screws. So they're the very small frag. I'm sure if you use Synthes, they probably have something similar. If you don't want to use a plate, you can use an external fixator. I did that in the beginning, and I'll show you that. But I use a plate now, and I put it on, and the screws go in the tibia. And this compresses and provides rotation and control. Then you line up the fibula and decide where to cut it. So now we're going to cut the fibula. Why didn't we do it before? Because the tibia could pull apart. So now the tibia is fixed in length. So now we can cut the fibula, cut it a little bit long so there's pressure, there's a compression, maybe 0.5 millimeter long, and then put it together, and then we put a wire up the fibula. Even sometimes if there's a defect, the wire goes in, out, in to the fibula. We then take a burr and shave the surface of the bone on the medial side of the tibia, the lateral side of the fibula. I'm sorry, the lateral side of the tibia, medial side of the fibula, and so that we are ready to create a cross union. At this point, we remove the tourniquet from the thigh. This usually takes about 2 hours. Next part is to open, make an incision, a bikini incision, split the apophysis, and then expose the periosteum on the undersurface of the iliacus muscle. You can take a big window of periosteum, and this will be our periosteal graft. We put it through a skin graft mesher so we can expand it because it shrinks right away. It shrinks by a factor of 4 times. This is the next step is the hardest step of the entire operation. And this step involves splitting the iliac crest. And we split it by opening the ilium, and we need for this very thin, sharp osteotomes. Now, I do this operation, the youngest child I start with is 12 months of age. It's technically difficult. And you need very, very thin, almost paper-thin osteotomes that will go in and do this. If you don't have that, it won't work. So we split the iliac crest, and we go slowly. We go all the way to the dome of the acetabulum. We go all the way to the SI joint. We go all the way to sciatic notch, and all the way to the triradiate cartilage here. And once we open the crest, and I'm telling you, this doesn't look so difficult. This is the hardest part. Once we open it, and we don't lift it up until we have completely freed it, it opens like a book, and we curette out all of the cancellous bone. I'm not interested in cortical bone. You must split the apophysis all the way to the back. And you can get there, if you look here, you can get there by cutting from on the top. And then when you get here, you cut from the inside until you go all the way to the back. So you remove all of this bone, all the way to the acetabulum and triradiate cartilage, until it is empty, completely empty. Here you see the osteotome going in, the curette removing the bone, and eventually you have like an air shadow. There's no bone in this crest at all, completely removed. And in a young child, you can get 20 to 50 cc's depending on the age. So 20 cc's is typical of a 1-year-old. 50 cc's probably is a 4-year-old. And this is a really big thing to get enough bone graft. So if you don't work very slowly and hard on this, you won't have enough graft and you will fail. Okay, so this is a really important step. Okay. Next, I fill this back up with some type of calcium sulfate, calcium phosphate, anything, any kind of bone void filler. I used to leave it empty, still nothing happened. Close the apophysis, and that's it. Now, at the CPT site, remember, our tibia is fixed, our fibula is fixed. We have 3 ingredients: bone morphogenic protein, we have periosteum, and we have cancellous bone. Now, I know that you probably, most of you cannot get BMP. Don't worry about it. This works without the BMP. BMP makes it go faster. Okay, it's more expensive, but it makes it go faster. But I go on mission trips to other countries, like in Haiti or Nicaragua, and I did the same treatment without BMP, and it worked fine. So I think you can do this without BMP. It might, my bones are healed in 6 weeks. 6 weeks, everything's healed. And with a really strong cross union. Maybe it'll take you 12 weeks to reach the same point, but you will get the same healing without the BMP. I think the BMP accelerates the healing. So we start by putting on the periosteal graft. Usually I go under the plate and I go around the bone. I usually leave the lateral side open now. I then put BMP in the back. So you see the bone morphogenic protein in the back. I then put the bone graft, and then I put BMP on top, like a sandwich. And then I close the muscle over top. So when I'm finished, I have a cross-union sandwich of muscle, BMP, bone graft, BMP, muscle. Now, what's the muscle represent? The muscle represents vascularity. So you have vascularized tissue full of mesenchymal stem cells, and the BMP recruits those cells into the bone mass. So because of the BMP, you're getting a lot more stem cells coming in. Of course, because this is cancellous bone, you have a lot of stem cells in here. This is your periosteum here, graft. And this is what you get in 6 weeks. By 12 weeks, it's very solid. There's a typical case here. This one you see ligament washers, which means that I advance the fibula down. So if it's a type B, I also advance the fibula down to restore the ankle mortise. Distally, it's locked in the epiphysis, proximally locked in the epiphysis. You see 2 lines, that's the zometa lines, 2 lines, zometa lines. So this provides unrestricted growth, and typically it telescopes and heals fine. Sometimes the rod pulls down from the top or up from the bottom if there's too much friction. Okay, so here's an 18-month-old boy with CPT, has NF. I did the same treatment, and the first 18 cases I did with this treatment, which I'm doing now since 2007, were with external fixators instead of plates. So there's nothing wrong with using external fixators. You don't need a lot of fixation. 2 wires below, each with an olive wire, 2 wires above. You don't even need to fix the foot. Just bypass the foot with a rubber sole and an extra ring for walking. Now this is 2-year follow-up. And this patient now I think has about 5-year follow-up. I should update my slides. So this is just an example. And you can put on, by the way, a hemiepiphysiodesis here. So you can put on a small 8-plate and realign the valgus. You see the valgus knee here. And even though you have a rod, it will realign. So it's a very nice little technique. This is a 5-year-old boy from China. And so here I did the cross union with plate. And you can see again, fasciae Duval rod, wire in the fibula, locked both ends, and then the plate in the middle. Everything is straight and aligned. So this is another case. This is a type 4A. Everyone asks me, how short a segment can you do? Can you do very short segments? Okay, so look at the small size of this here. And this is how small it is. This is 1 centimeter. Okay, you see 1 centimeter is the whole bone. That is the cut in the periosteum. There's the bone exposed. And of course, I have to cut it partially off. So how do you fix something so small? So here's still the fascia Duval rod, the wire in the fibula. And now the fixation is with a T-plate. And the T-plate goes, the screws go in the epiphysis. You see here in the epiphysis. And that's how you fix it. Cross union occurs, as you can see here. And then what I do is I remove the screws from the epiphysis and I add them into the metaphysis. Proximal ones are even more rare, and you have a bigger lever arm of fixation and healing. So this one, I had to take down the all the way up to the artery where it comes through. I'm grafted here to get a proximal cross union. I had to do an osteotomy because look, there is this varus deformity here. I couldn't put a rod down. So there's an osteotomy, and I had to do a second cross union at the site of the osteotomy. So I shared my bone graft between both sites. And that is how the patient is now. This is a very interesting one. It's a child from Italy. And look at this. The child already failed 2 surgeries in Italy. And they have a flexion contracture of the knee and a recurvatum deformity of the tibia. And they wanted to do an amputation here, which wouldn't solve anything because this part is in flexion. You can see the CPT site is here. So what do you do here? So what I did is I did a posterior capsulotomy and I released the knee capsule and extended the tibia forward. Okay, so extended the tibia forward. Then I rodded it in surgery with, this is not a telescopic rod, it's called the slim rod, it's a 1-piece rod. And then after doing that, I added a plate from the proximal to the distal end of the tibia to stabilize, of course, a wire up the fibula. Even though there's a defect in the middle, that's okay. And then let it heal. And this is before surgery, confirming that the ankle could move down. And this is looking at the knee in maximum extension. The reason I want to see that is, does the knee reduce? If it reduces, I don't need a posterior capsulotomy. But it wouldn't reduce. So I did a posterior capsulotomy and reduced the subluxation. And then you can see here, drilling open the canal. And I would have to go inside, outside, inside. And that's what I did. Inside, and then I'm exiting, and then I'm going to come out here. So what I did is then did an osteotomy. You can see the tibia here. Reposition this into the correct angle, and then put in an antegrade nail. So now the tibial plateau is in the correct angle. Fix it with the plate from the outside, like an internal, external fixator. The wire up the fibula. And now you see here, this is healed. So it's a solid cross union all the way across. So this, we did a retrospective review from 2007 to 2018, 34 patients, 36 limbs, all were treated with the cross union protocol, 18 with X-Fix, and average age was 5.4 years, and 18 with plates, average age was 3.5, so about 2 years younger. So we're getting younger and younger. Most of my patients are between 12 and 24 months old. This is the age group that traditionally does not do well. All kinds of different types. I'm sorry, this slide doesn't line up, but we even had some that the tibia was not broken and we broke the tibia. I know that sounds like heresy, but it's really not difficult to get a tibia to heal. If you can get a broken one to heal, you should be able to get an unbroken one to heal. The X-Fix, when it was on about 4.5 months. I'm sorry, no, was on, sorry, no, that's not what this is. The X-Fix, the average age was 4.5 years, 3.5 years. We already talked about that. NF1 was present in the external fixator group in 67% and in the plate group in 83%. We had some osteofibrous dysplasia and some idiopathics, and previous failed surgery was present in both groups. So we have follow-up up to 12 years in the X-Fix group and up to 5 years in the plate group. So we now have, you know, that's pretty decent follow-up. Only 4 patients are skeletally mature in the X-Fix group, of course. And you can see the results. 36 out of 36 achieved union, 100%. 36 out of 36 achieved cross union, 100%. 0 out of 36 had a refracture, 0%. But the fibula failed to unite in 3 out of 36, 8%. One of the reasons for this is we now learned that when you have a very low fibular non-union, you have to strip the periosteum even lower on the tibia and put bone graft way down there. I don't think we were doing that originally. We had very few complications with 3 cellulitis treated with antibiotics, 3 pin track infections. They had 1 locking wire of the tibia back out, which had to be replaced, and 2 incisional skin necroses, which required debridement. 1 of them needed a skin graft. The fascia Duval pulled out proximally or distally from the epiphysis in about 17% of cases. And we had, most of them were X-Fix cases, interestingly. Not sure why. These cases that the fascia Duval pulled out on were almost always the ones that developed proximal valgus. And we think what's happening is when you get valgus proximally, it puts a bending moment on the rod, and the male and female part jam. You get what's called stiction friction, and they won't telescope. So it pulls out of the epiphysis. So we anyway plan a rod exchange. So when they're normally going to come for a rod exchange, we will then change their rod and fix this problem. You can see here, this pulled down from the top, up from the bottom. So we would remove this, it's not easy, and then we would re-rod it the normal way. Now, what about the effect of this on the hip? You're taking a lot of bone right from the acetabulum area. We looked at the CE angle and the acetabular index, and we found there was no change in AI or CA between sides. This was at a minimum follow-up of 2 years. One of the effects of the bone graft is sometimes we end up having to transfuse for loss of blood. Now, what's the history of cross union? Well, credit is deserved to In-Ho Choi from Korea, who published his technique called 4-in-1 technique using cross union earlier than I did. He published in 2011. And he looked at the cross-sectional area. He did it a little different. He would converge the fibula to the tibia. So his cross-section area is not quite as wide as ours. he defined a thing called the relative cross-sectional area, which is the width here divided by the width of the epiphysis on AP and lateral. And the relative cross-sectional area was 0.13 in patients who had no cross-union. And these patients refractured in all cases, almost 4 out of 5 cases. The patients he treated with the 4-in-1 had cross-sectional area, relative cross-sectional area 0.27, had no refractures in any of his 8 cases that he published. And we compared to our method where we keep a rod in the tibia, rod in the fibula, and we had a relative cross-sectional area of 0.56, much wider, twice as wide as in Ho Choi. So I think our technique is much stronger and depends on our bone graft method. He does a different bone graft method. So I would still recommend our method of doing this than his. Now, I published an article in the same year, in 2011, or maybe it was 2012. So I never saw his article at the time that we published our first publication on cross-union. So I do have a publication dating back to either 11 or 12, but we never read his. But even though I'd never read his technique, he did publish first, and their technique, they were doing intentional cross-unions since 1999. I started since 2007. Really, the concept of cross-union for CPT, the first person to do it intentionally was In Ho Choi and his Korean group. We do ours differently, and although I didn't learn it from him, they do have priority in terms of timing of publication. So the conclusion, we get very rapid union in 3 months, 100% of CPT union rate, 100% union or cross-union of the tibia to the fibula, and no refractures at an average of 4-year follow-up and up to 12-year maximum follow-up so far in the series. Actually, it's almost 13 years now. We had a few persistent non-unions of the distal fibula, which now that we're paying more attention to that, we're not getting any non-unions of the distal fibula. So I think this is a paradigm shift. You know, our success rate we redefined as union without refracture, which is a much higher bar for success than just union or refracture. 100 years of literature has shown us 50% success rate. Cross-union has shown us 100% success rate. In my hands, similarly in Ho Choi, and I've had now numerous people reproduce these results. So it will remain for others to reproduce the results. I think it's a technique that if you're seeing a lot of this, it's worth doing. If you're not, send it to someone who is going to do a lot, because there is a learning curve. And especially harvesting the bone graft seems easy, but it's not. So I think that we will be seeing more papers corroborating our results. Maybe they won't be 100%. I'm a perfectionist. I've done this a lot. Maybe someone else won't get quite as good, but they'll get 80, 90%. That's still better than 50. So I think this is very promising, very encouraging. Now, I thought I'd show you a few little modifications. So type 4B, we looked at 4A. Type 4B, the fibula is migrated proximal. So in these cases, we want to reduce the fibula while we're doing this. So we extend our exposure distally. We move the perineal vessels, which run over the syndesmosis. And then we cut the anterior and posterior tibia-fibular ligaments. This frees the fibula from the tibia. We square off the tibia, drill it, rod it. We already talked about that, plate it. And then, now that the tibia is stable and the length is determined of the tibia, we can push the fibula distally and then pin it with a wire or a syndesmotic washer system. And so we fix that wire in place to keep it from migrating up. We also rod the fibula, as we said, square off the end, rod the fibula, and then we do the rest of the cross union with the bone graft, and et cetera, all the same. That part doesn't change. Okay, so that is for the type B. So it's 2B and 4B. So here's an example, it's a 4B, both bones. Now this is a very small fragment, which, that was 6 months of age. This is 14 months. You notice the bone has disappeared. There's almost no growth plate. Now I know everybody wants to save this. Well, a lot of people want to amputate it, but to save this, everyone wants to put a rod through the ankle. So I would tell you, you don't have to do that. I used a T-plate and fixed into the epiphysis. If you're using a fixator, put the wires in the epiphysis. Then do every step the same. This was a B type, so I brought the fibula down and I pinned it with this wire. And you can see the end of the fibula is way down here. Look at the cross union. Only 3 months post-op, this is what it looks like. I left the screws in the epiphysis for 3 months. Then I removed these screws and look at the plate moving away as the distal part grows. I think that's the fantastic part, is look at the plate migrating upwards, because it's still fixed here, as the distal part, growth plate, grows. So this is proof, this is 16 months after surgery, that we were able to spare the growth plate even in this very distal case. This one's a 12-month-old, type 4B, and same thing. We had enough bone, so this was enough. We didn't need a T-plate, okay? But we moved the fibula down, and this is 3 months after surgery, 2 years after surgery, and you can see now the rod pulled out of the epiphysis, but beautiful cross union. Fibula is a little bit short here, so we're going to revise this a little bit, just to hit the level of the fibula. What about the non-broken ones? This is type 1. So here, we remove the hamartoma, the membrane. We cut the apex of the deformity, cut the apex of the fibula, straighten the bones, square them off, and then plate and rod the tibia, wire insertion to rod the fibula, and then the BMP, bone graft, and muscle. So that is the cross union. When you start with a non-broken bone, this was the old technique with a smaller plate. Now I use a longer plate. This was my first one, 2014, with the plate. You can see patient healed. I used to make smaller cross unions. Now I make much longer ones. I think you should try and make longer ones. And you can see 2016, we did it in 14, and this pulled out and developed this curve here. So, but it's well aligned, but there's no straight line to put it in. So I switched it to a, I switched it to a solid rod. I took this out and put a solid rod down here. Another one, this one's not broken in the tibia, broken only in the fibula. So we broke the tibia. We're not afraid to do that. And we used a plate. You can see here the cross union forms before the CPT even heals. There's the maturation of the graft, and you can see here the growth away from the plate. Plate used to be down here. And this is the changing of the rod. So you'll go from a fully telescoped or partially telescoped rod and then change it to a new telescopic rod. So usually I change this about once or twice during the growth. Typically, if I do this at age 1, I have to change the rod at age 4, and maybe again at age 12. Here's another one, an intact tibia, a child from Brazil. And then I did the osteotomy, straightened it, cross union. Again, exactly the same. So this is basically, I've shown you, you know, the options that we have and the technique that I use. I'm open to answer any questions. I'm seeing the list of, I don't know if anybody's going to moderate, but I see some of the questions.
Hello?
Yeah.
Yes. Yeah, Dr. Billy, thank you so much for this wonderful presentation and wonderful talk about all types of CPT and how to solve this issue. And I think these types of surgeries need like a lot of learning curve rather than just trying to recreate what you have already mentioned. Is this right?
Yes, I do think that, although I think this is a very learnable technique. I think, though, if you're going to see a lot of CPT, you should learn how to do this. I think if you are not seeing a lot, you probably should refer the case. You shouldn't do just one case your first time and you never do another one. So I think that if even if you see one a year or two a year, that's okay. Then you should learn this. I think that one thing for sure, the results are so dramatically better than all other techniques. There's no technique out there that even comes close to these results. I think that the other methods need to go away. I think until someone can show 100% union, no refractures, the other methods need to go away. This is very reliable, and I think that we now need to really, this needs to become the gold standard.
Okay, so now according to our schedule, less than 10 minutes for Novartis talk. You can just get something to drink, and we will ask you a few questions after that and to conclude the session. Okay, sir?
Okay, so 10 minutes?
Yeah, just 10 minutes.
Yes, good evening, Professor Drohan. Good evening to everybody. Thank you, Professor, so much for the eminent presentation. I think everybody has been very interesting during this talk about the congenital pseudoarthrosis tibia. And thank you for making the presentation very simple and your presence. شكرا جدا لجامعة الأزهر على يعني المشاركة الظريفة جدا والسيشن المحترمة قسم العظام جامعة الأزهر. فثانك يو دكتور أحمد وكل التيم. أنا حسام شاهين نوفارتس تيم في الميديكال ديبارتمنت براند امباسادور. ان شاء الله مش هاخد وقتكم كتير، انا هتكلم من الناتشل على نوفارتس دايكلوفيناك رينج او كل البرودكتس اللي يعني موجوده في نوفارتس عن مولكيول الدايكلوفيناك. طيب تمام. اول حاجه احنا عندنا كذا برودكت هم الدايكلوفيناك مولكيول بس موجود بكذا فورمولا، وده علشان حضراتكم تقدروا ان انتم تستخدموه على حسب البيشنت اللي موجود ويقدر ياخد الماكسيمم بنفيت بيزد اون الكيس بتاعته. فاول حاجه هبتدي بيها بس معلومتين. اول حاجه انه احنا الديكلوفيناك هو مولكيول انتي انفلاماتوري انالجيسيك. القصه فيه انه بيعمل انهبيشن كوكس 1 كوكس 2 از ريزلت بيحصل انتي انفلاماتوري افكت وانالجيسيك افكت. تاني حاجه احنا الدوز الثيرابيوتيك دوز للمولكيول ده 150 مللي جرام في اليوم، فده الثيرابيوتيك دوز ريكومندد. طيب اول برودكت موجود عندنا او الفورمولا نمبر 1 هي الارثروفاست. الارثروفاست ده التابلت فورم الجرعه فيه او الدوز فيه 150 مللي جرام. الفكره فيه او التكنيك بتاعه هو بيبقى يعني باي لاير. اللاير الاولانيه بتبقى 25 مللي جرام وده بيحصل لها immediate release يعني افتر الادمنستريشن على طول، فبيبقى ليها افكت سريع جدا، وبقيه الجرعه 150 بيحصل لها سستين ريليز ثرو ال 24 ساعه. فده بيبقى فيري امبورتنت لحالات الفلير اب اوستيوارثرايتس روماتويد ارثرايتس وكمان اللو باك بين او اللي هي حالات الاكيوت اون توب اوف كرونيك. طيب طبعا حته الاميديت ريليز دي فيري امبورتنت لانه على طول بقى اول ما يجي له الاتاك الجزء الاولاني اللي بيطلع ده بيسبب يعني بيخلي الكواليتي اوف بين بتقل جدا بالذات الارثرايتس بين. طيب يعني مميز في البرودكت ان هو يعني الارثروفاست هي بتبقى العلبه فيها 14 تابلت، فده الدوز الوحيده اللي موجوده او الدراج الموجود لحالات الفلير ابس اللي موجود فيه الدوز اللي فعلا البيشنت محتاجها، لان هي بتتاخد 14 يوم اللي هم ال2 ويكس 1 تابلت بير داي لمده 14 يوم او ال2 ويكس. تمام. ده بالنسبه للارثروفاست. عندنا الكبسول فورم او الفورم اللي هي موجوده 75 مللي جرام من فلوتاك. الفلوتاك الظريف فيه ان هي بتبقى كبسول وفيها الدواء الدايكلوفيناك ماسك في كوليسترامين، ده بيبقى ناتشرال ريزن، بياخد الدواء من الاستومك بينزله السمول انتستين ويحصل هناك الريليز اوف ذا دراج، فبيبعد خالص عن الاستومك ما بيبقاش فيه اي ميوكوزال دامج، فده اتس فيري كونفينينت فور اول بيشنتس اللي عندهم ايشو في الجي اي تي سايد افكتس. طيب ده لحالات ايه الفلوتاك؟ حالات كرونيك اوستيوارثرايتس. الحالات دي محتاجه تاخدوا فتره طويله، فبنقدر نديهولهم على جزئين. الجزء الاولاني اول جزء اللي هم ال 14 يوم هناخد الفول دوز اللي هي ال 75 مللي جرام كل 12 ساعه، فنغطي كده يبقى كده ال 150 مللي جرام في اليوم لمده 2 ويكس او 14 يوم. وبعد ال 14 يوم عندنا مانتننس دوز اللي هي اب تو 3 مانثس، بناخد 1 كبسول بس في اليوم، دي اب تو 3 مانثس بعد ال 2 ويكس. تمام. دي ستادي اسمها الامري. الكونكلوجن فيها انه الدايكلوفيناك مولكيول ليه 2 فولد ريدكشن للارثرايتس بين كومبيرد تو السيريكوكسيب فاميلي من الدروجز. بعدين عندنا كمان الانجكشن فورم او التو هم 2 برودكتس. اول واحد الكتافلام امبول. الكتافلام امبول هي دوز بتاعته 75 مللي جرام في الامبوله، فاحنا بنحتاج 2 امبولز بير داي عشان ناخد ال 150 مللي جرام، وبنقدر ناخده لمده من يومين ل3 ايام مش اكتر من كده، زيه زي اي ريجوليشن للانجكشن في العالم. طيب بناخده امتى؟ في حالات ايه؟ في حالات بوست اوبراتيف، في حاله محتاجاه، او حتى فراكتشر او اي بروسيجر حضرتك عملتها وشايف ان البيشنت محتاج انتي انفلاماتوري وانالجيسيك ايجنت. طيب عندنا كمان الفكره فيه ان هو الباور اوف 10، هو 10 مينتس يبتدي خلاص الاكشن بتاعه بيشتغل، بيحصل يعني بيحصل افكت كويس جدا كانالجيسيك البيشنت بيحس بيه بعد 10 دقائق، وده وقت طبعا قليل جدا، وده اسرع امبوله موجوده اصلا في الماركت. طيب عندنا كمان الفولتارين امبول. الفولتارين امبوله ديكلوفيناك 75 مللي جرام، بس الايدج فيها هنا او الفيري انترستنج ان هي بنقدر ناخدها على انترافينوس، فبنقدر نعمل لها دايليوشن على سلاين او جلوكوز، ما نقدرش نديها خالص انترافينوس بولس، لازم يحصل لها دايليوشن. وبتبقى كويسه جدا في حالات البوست اوبراتيف اللي هم لسه في انستيزيا ومحتاجين ياخدوا حاجه انالجيسيك، مش هيقدروا ياخدوا حاجه انتراماسكولر، او اي حاله يعني اي كيس بيد ريدن حضرتك شايف ان هي مش هتقدر تاخد حاجه انتراماسكولر، فده فيري فيري جود يوز للفولتارين امبول. وبرده بناخده لمده يومين ل3 ايام مش اكتر من كده. طيب البيشنت بقى خلاص يعني هو خلص الدوزز دي من الانجكشن ومحتاج يكمل على انتي انفلاماتوري انالجيسيك، احنا مش هنقدر نكمل له انجكشن، ففي اللي عندنا الكتافلام 50. الكتافلام 50 هي تابلت فيها ال 50 مللي جرام ديكلوفيناك كده، يبقى احنا عشان نغطي ال 150 هناخدها 3 مرات في اليوم كل 8 ساعات. والكويس فيها ان هي اصلا اسرع يعني تابلت موجوده في كل الفورمز ال 50 مللي جرام، فبتبقى بعد 20 مينتس، يعني 20 مينتس دي الماكسيمم افكت بتاعها، فبرضه البيشنت بيقدر ياخد الماكسيمم بنفيت في وقت صغير جدا، سبيشالي في حالات البيت، وبرضه حالات بوست اوبراتيف او حالات فراكتشر او اي بروسيدور محتاجه انالجيسيك وانتي انفلاماتوري دراج. طيب في كمان عندنا الكتافاست. الكتافاست دوت في نوفارتس الساشيت فورم، اللي هي يعني بتبقى موجوده جرانيول فورم، مش ايفرفيسنس، مش فوار خالص، هو جرانيول 50 مللي جرام، برضو بناخدها 3 مرات في اليوم عشان تغطي ال 150 مللي جرام كل 8 ساعات، وهي لحالات سبرين وسترين مينلي. وطبعا حضرتك تقدر تستخدمها لو في بيشنت مش هيقدر يسوالو تابلت ولا ياخد حاجه انجكشن، في ناس بيبقى عندها فوبيا من ده او من ده، فبيبقى ده السولوشن اللي موجود. وبرضو بيدي الافكت بتاعه سريع جدا، لانه من اول 5 minutes ل 13 minutes بيدي الاكشن بتاعه، فهي يعني معروفه كمان ان هي اورال انجكشن من كتر ما هي سريعه جدا في الايفكت بتاعها. في بقى اخر حاجه خالص عندنا الكتافلاي، وده معمول للسبيشال بوبيوليشن للتشيلدرن. النوفارتس عامله الفورميولا دي ليه؟ عاملاها علشان اولا طبعا حضراتكم بيجي لكم لو في حالات فراكتشر او حالات محتاجه انتي انفلاماتوري انالجيسيك، وكمان في حالات فراكتشر بيبقى جاي از ريزلت ليها بيبقى في فيفر، فبيبقى هو 3 في 1 الكتافلاي، انتي بايريتيك وانتي انفلاماتوري وكمان انالجيسيك، جاست وان دراج في الثلاث سيرفيس اللي حضرتك محتاجهم لاي تشايلد. الكويس فيه جدا بقى ان حضرتك تقدر تديه على البادي ويت، على الدوز اللي التشايلد ده محتاجها، ولا ازيد ولا اقل. فدي بتبقى حاجه فيري فيري يعني امبورتنت لاي فيزيشن ان هو يقدر يتعامل بيها مع تشايلد. طيب بنحسبها ازاي؟ هي ربع وزن الطفل 3 مرات في اليوم، فهو لو الطفل ده 20 كيلو هيبقى 5 مللي 3 مرات في اليوم، عشان نسهل على الام، لان طبعا الدراج ده بريسكرايبد من اول سنه، احنا معانا من اول سنه نقدر ان احنا نعمله بريسكريبشن. فلو ام هتستخدمه لطفل وهتسحب بسرنجه السوليوشن السسبنشن، نقدر ان احنا نقول لها ال 5 مللي دول اللي هم ال 5 سم عشان نسهل عليها. وطبعا هو بتعمل ستروبري، هي سينثيتك فليفر مش ناتشرال، فحضرتك برضو تقدر تديها وانت مطمن لاي بيشنت عنده حساسيه من الفراوله او من اي برودكت لاي فروت من البيري فاميلي عموما يعني. انا كده خلصت البرزنتيشن دي، كل البرودكتس ان شاء الله كل البيشنتس يعني يستفادوا من كل برودكت على حسب ما حضرتك شايف هو محتاج انهي فورمولا بالظبط من الديكلوفيناك. اخر حاجه بس، طبعا حضراتكم عارفين due to الكوفيد 19 الكورونا كرايسيس، احنا يعني we are all working from home، وطبعا ده حفاظا على صحه حضراتكم وكمان الانترنال اسوسيتس في النوفارتس عشان نسيز او نوقف ما يبقاش فيه انفكشن. فاز ريزلت احنا بنتواصل مع حضراتكم فيرتشوالي على التليفون وكمان على المايكروسوفت تيم والويبينار زي اللي احنا فيه دلوقتي، فمحتاجين بيرميشن من حضراتكم انه حضراتكم موافقين على البروسيس دي. نفس السكرين شوت اللي ظاهره دي موجوده على، يعني لو فتحتوا الايميل عند حضراتكم في ايميل جاي من نوفارتس في نفس السكرين شوت دي. حضرتك لو عملت بريس على باتون يس اي اكسبت، حضرتك كده بتدينا بيرميشن نتواصل معاك الفتره اللي جايه فيرتشوالي على التليفون والويبينارز وكمان المايكروسوفت تيم ميتنجز اللي احنا بنعملها، نقدر نعمل لحضراتكم انفيتيشن. ثانك يو تاني على يور يعني اتنشن ويور اتندنس، وستي تيوند. يعني الكيو ان اي سيشن لحضرتك اي حد طبعا محتاج يسال اي سؤال يو ار مور ذان ويلكم ان حضرتك تسالوه دلوقتي. وثانك يو فيري ماتش.
شكرا دكتور حسام. لو في حد عايز يسأل الدكتور حسام حاجة على ما دكتور بيلي يرجع لنا تاني. أنا بطلبهم. الو شيخ.
طيب تمام. بالنسبه للسؤال الكتافلان امبول ان هو متوفر او لا، الكتافلان امبول متوفر. ففي دكتور كان بيسال انه الافيلابيلتي للكتافلان امبول هو موجود دلوقتي ومتوفر.
Okay, he's coming. I called him. He's coming right now.
دكتور محمود انا اسف، دكتور محمود حراز اعتقد. الكتافلان امبول موجود يا دكتور، فهو افيلابل دلوقتي في كل الصيدليات.
في دكتور بيسأل يعني؟
في دكتور كاتب كويستشن على الشات.
اوكي. طبعا في أسئلة جاية بخصوص الفيبولار موفمنت. Restriction due to cross-union technique have any negative effect on the ankle mechanics? What about shortening? Any special considerations in future lengthening? Okay.
Okay, I'm back.
All right, welcome back.
Okay.
So,
any questions?
Yeah, I will forward to you every question. There is not too much. The first question from Dr. Abdallah Nada: does fibular movement restriction due to cross-union technique have any negative effect on the ankle mechanics later on? If you're doing cross-union between tibia and fibula, yeah.
And move the fibula?
Yeah, when you fix the fibula.
It heals in the new position. So, you know, the problem is they get ankle valgus when you leave the fibula migrated proximally. So,
yes.
You know, I only do it if there's a significant migration. So,
so by cross-union technique between tibia and fibula, there is no effect on biomechanics later.
Oh, you're talking about the fusion between them?
Yeah. Yeah.
No, I don't see any biomechanical. The issue is bigger. We haven't answered this one, but you know, the distal fibula grows slower than the distal tibia, and the proximal fibula grows faster than the proximal tibia. So the question is, will this cause any change in level? We tried to look at that, and we have not gotten a definitive answer on that. So it doesn't seem to be a big issue.
All right. Another question from Dr. Ahmed and the same from Dr. Talal. What about shortening? Any special considerations in future lengthening when you can do this?
Oh, for leg length difference?
Yes.
So I think that a couple things. So I do lengthen them, and I have many of them that I've lengthened, but I don't lengthen them at the same time anymore. Especially in the young kids. Sometimes in an older child I will, but in the young kids, I don't lengthen them at the same time, and I let it heal. And then it's a much smaller problem to treat. So in the future, I lengthen over the telescopic rod through a proximal osteotomy using an external fixator. and I change the rod at the end after the bone is healed. But I really do not recommend lengthening and treating this at the same time. There's no reason we need to do that. Other interesting thing is, I think the hamartoma resection, because it liberates the periosteum, so you no longer have, normally periosteum runs from one zone of Ranvier to another. It tethers the two growth plates at either end. It's actually the check mechanism for growth. When you take out the hamartoma, you get a growth stimulation. The leg grows faster. And when they start weight bearing normally, the leg grows faster. When you have hyperemia, the leg grows faster. So sometimes I get 2 centimeters of extra growth on the affected side. So if you wait, you're going to have less leg length difference. Wait at least 2 years. So 2 to 3 years, especially in young children. Interestingly, because of the zomida, you get these lines going across the tibia. And those lines can be used to monitor the growth rate, because you can see how much growth from each side. What we're seeing is that in the beginning, for the first year or two, we have faster growth on the CPT side than on the other side. So really remarkable, these cases. I also, a very important point, and I don't know if I emphasize this, in CPT, you get a lot of secondary changes. You can get, secondary changes of the foot. You can get cavus. You can get, especially a calcaneocavus, because the gastrosoleus are defunctioned. You get a valgus ankle. You get subluxation of the ankle. You get changes at the knee due to recurvatum, especially. We showed you one example. You get changes at the hip. You get a valgus neck. You get overgrowth of the femur. So we want to prevent these secondary changes. And the way to prevent it is to get this to heal quickly. The longer you wait, the more secondary changes, like proximal fibular migration and so on. So I like to treat them early. I start even at 12 months of age. And then you avoid and prevent all these secondary changes.
Okay, another question from Dr. Ahmed. What about Elijarov with transverse fibular graft transport, like getting the fibula from its position to the tibia, like fibular graft?
Yeah. So I have a question for whoever is asking a question like that. You can't get better results than we have. Why do you want to start looking for, maybe how about this new idea and this idea and this? All of these things can be done, but they have no proven track record. I think if you have a very large bone defect, if you have a 20 centimeter bone defect, it's a reasonable consideration. So is a vascularized fibular graft, but really has no role. This method works for almost every single case, and it's very reliable.
So the failure rate from fibular graft is much more than the cross-union technique, right?
Yeah, I think using a fibular graft has many, many disadvantages. Both on the ankle, on the knee, and then you lose this advantage of doing a cross union because you don't have the opposite bone, to cross unite. I mean, the reason this works is because it creates such a large cross-sectional area, the bone can never break. It's impossible. If the child's in a motor vehicle accident, the other leg will break, but this one won't. Because it's not only wide, but it's got metal inside the fibula and tibia. It's impossible.
Got it. So one more question from Dr. Amr Arafa. When is the patient allowed to complete weight bearing?
So we allow weight bearing at 6 weeks after surgery.
Mhm.
So for the first 6 weeks, I don't allow weight bearing because of the pelvis. I like to leave it alone. So first 6 weeks, they're in a cast, but no weight bearing. And then at 6 weeks, I make them articulated AFO brace, and I allow them weight bearing as tolerated. So they're
Okay,
starting
and
6 weeks after surgery.
And when usually you remove the implant, when it is internal fixation by plate?
So I leave it there until it's time to change the rod.
Okay. Have you ever noticed while using the telescopic nail any complication of physeal arrest or injury?
One time, not from the nail. I had one case where just a technical error that I made, and when I pushed it in, I didn't cut the female part short enough.
Mhm.
So I banged it, and it pushed the male part down, and it broke the distal tibial physis. And that fracture, I don't know if so we injured the physis. It might still be growing. I saw a recent x-ray, I think it is growing, but I had a fasciolysis, intraoperative fasciolysis, because I didn't cut the female end short enough. So you got to make sure we cut these and prepare it. You got to make sure you cut it the correct length.
Okay. So how to avoid skin problems, compartment syndrome, problems of healing, and secondary infection in such cases?
I never had an infection. With a fixator, you have a risk of infection, but with the plate, I've never had an infection. I had 2 wound necrosis. They both occurred on the medial side. I understand the problem now. So when you do this and you make the incision, there's a thin layer of fascia, which is sometimes even adherent to the hamartoma. So I shave a thin layer of this off and lift it with the skin. I never lift the skin off the hamartoma. So I lift it with this fascia. The vessels run in the fascia. So then with this thin layer of fascia, the skin has been fine. I've never had another incident of this again. So just 2 times early on.
Okay. A question from Professor Ashraf Khamfour. For pre-fracture cases, I am wondering if it was left and followed up. I had 2 cases of neurofibromatosis 1 in a family. All have neurofibromatosis except the father and the condition. I mean, the question is, in cases where there is no fracture yet, do you treat or leave them?
So I treat them, and I'm not afraid to break them. But I'm very good at this. I have no failures. So for me, to break it, straighten it, rod it, is okay. I don't fail. The danger, if you're not, I wouldn't do that as your first case. If you get good at healing the broken ones, I did recently see an interesting treatment from Mark Dahl from Minneapolis. He puts like an 8-plate anterolateral on the distal tibia growth plate, a distal tibial physis, and causes it to remodel. Kind of reminds me a little bit of what happens with posterior medial bow, how it straightens out. But he puts this hemiepiphysiodesis plate. Now these are in the ones that are not broken. I think that's also a reasonable treatment, anterolaterally. I've not done that, but I might do one, the next one I see. But for me, I showed you the not broken ones, I break them. doesn't bother me one bit. But remember, I'm experienced at doing this. So don't start with those.
All right. Do you have any idea about using the fish mouth technique in dealing with the fractured tibial ends? Fish mouth technique?
Yeah, it's the invagination of one side to the other. I did that. I even published it. It's a technique I learned from the Russians, and I modified it. I don't think it's particularly useful. I think you get more risk of bone necrosis, especially if you strip off the hematoma. So I don't use that anymore, and I square the bone ends and I bone graft around them like the way I showed.
Okay, so there are some surgeons asking about deep infection after using external fixation with internal rush pin or telescoping nail. How you deal with this deep infection if present?
Yeah, if you have that, you have to take out the nail. We now we ream the canal. We then inject the canal with calcium phosphate impregnated with antibiotics. So not phosphate, calcium sulfate. Calcium sulfate impregnated. That's plaster of Paris, sterile plaster of Paris. And we use that with the antibiotics, and we put a new nail inside the calcium sulfate. And this sterilizes the canal. So it's an absorbable cement spacer. And this is a good way to sterilize the medullary canal.
Okay, so a question from Professor Hisham Al-Ashri. In case of young, small kids, wouldn't you recommend waiting until the bones are long enough so you can deal easier and more successful, or you start working from early on?
No, so the problem is if you wait, you get secondary changes. So maybe it makes it easier for you to do the surgery, but then you have new problems. Like I said, you have a leg length difference, you have ankle valgus, you have subluxation of the fibula, you have cavus deformity, you have weakness of muscles, you have, valgus hip, you have recurvatum proximal tibia. There are many things that develop, and you have much more disuse osteoporosis. So I think it's a bad idea to wait. If you're not able to do the surgery at a young age, send it to someone who can.
Okay.
And I think that's important. Look, not everybody is technically good enough to do this in very small bones. I can. I'm very used to doing this. I think most of them should be treated between 12 and 24 months. Now, of course, it's easier to treat child 24 months than 12 months, but you pay for it. You get more secondary changes. So I like to prevent the secondary changes, and so I get them healing quickly. And the child has a normal life very quickly, never breaks. I let them do all sports. Okay, I have them wear a brace for sports, but I let them do any sport. I even have one child, mother wants him to do kickboxing. I let him do it. Okay, they're never going to break. Okay.
Great. Technically, intraoperatively, you're still removing bone and periosteum until you notice bleeding. And how can you do this while using the tourniquet? How can you notice there's bleeding coming from the healthy bone?
I didn't say anything about bleeding.
I know. Just one asking if you removing.
I don't. I do it under tourniquet. I remove the hematoma. I don't worry about bleeding.
Bleeding surface.
I don't worry about bleeding surface. I don't worry about seeing, like paprika sign. I don't worry about dead bone. I just remove the hematoma. I don't remove the bone. I don't resect bone. I want to make this clear. I do not resect bone. This has nothing to do with the treatment of pseudoarthrosis. The only bone I'm removing is when I start like this and make like this and it's overlap, I remove just to bring the overlap bone together, to have not point to point, but flat to flat. That's all I do. And I take off only as little as needed. But I'm not resecting the pseudoarthrosis. This idea that you must resect the bad bone is nonsense. There is no bad bone. CPT is not a bony disease. It's a periosteal disease. The bone is injured secondarily. The bone is not part of the pathology. The pathology is the periosteum. That's why you find this tumorous involvement of the periosteum, the hamartoma. The bone, yes, it reacts, which shows you that it's alive. It becomes sclerotic. It becomes atrophic, okay? But this is because of the osteoclasis. This is because of the lack of BMP. And so we can treat that, but you do not need to resect the bone. This is a complete mistake. It's a fallacy. And whoever came up with those ideas, they're wrong. They're 100% wrong. The only dead bone you find in CPT is if someone operated on the bone and devascularized it. But even in those cases, I don't resect the bone. I bone graft around it and it will reconstitute. So I just, unless it's infected, that would be the only reason. If you had an infected non-union, then you are stuck. Then you have to resect some dead bone.
Okay, two questions about the using of zoledronic acid in like a couple of doses in just 3 months. Is it too much for these kids? And what about the BMB? We don't have this. So do you still think that without using BMB, we can get the same results?
Yeah, so I take the second question first. I already answered the BMP question. I said that I know that this is expensive. I know you don't have this. And I just don't use it. Forget about it. And you'll get the same results. It might take 12 weeks instead of 6 weeks to get the same result. But it's fine, not a big issue. So the BMP is not essential. It's nice. It's like a luxury, okay? Okay, in my hospital, we don't have any money problems for buying BMP, so we use it. But when I go to some very poor countries to operate, and I've gone to not poor countries. I did a case surgery in Israel, which is not a poor country, and they didn't have BMP, so I did it without BMP. I did a couple cases, and they healed. Same thing in Nicaragua and Haiti, which are poor countries. I didn't have BMP, and everything healed. Okay, so that's not a problem. The second question is about zoledronic acid. So zoledronic acid, to me, is more important than BMP. Okay, so if you don't have zoledronic acid, I'm sure you can get some pomidronate. Use pomidronate. Use it preoperatively. It is very, very important. That really relates to the, the pathology that we're dealing with here. Okay, using the pomidronate. I would recommend that, what was the question about zoledronic acid?
Is it 2 doses in 3 months? This is too much for these kids?
No, 2 doses in 3 months is not a lot. It's fine. At our hospital, they won't give it before 12 months of age. So that's why I wait to operate until 12 months. But no, 2 doses is a very small amount. Think of the OI patients who get every 3 months they get another dose. No, this is nothing. We have almost no complications from zoledronic acid. We had, patients frequently get like a flu-like symptoms, muscle aches, joint aches for 24 hours. We have had a few idiosyncratic reactions. I had one patient become neutropenic and thrombocytopenic. I don't know why. And, we never used the second dose. So I think that there are some exceptions where but you don't know. I had one patient who developed really severe pains, but they were giving it too quickly. And then when we modified, they gave some Benadryl and some other things, and then they had no symptoms. So just a few patients we had with some funny symptoms, but really we never had any of these complications like avascular necrosis of the mandible or any of this, because we're not using large doses and we're not using frequent doses.
Okay, so sorry, Dr. Billy, just a few more questions, that's it. Professor Isharab is asking about, instead of BMB, can we use platelet-rich plasma or bone marrow concentrate like frequently during or after surgery, like injection in the CPT site?
To use what? PRP?
Platelet-rich plasma, yeah, or bone marrow concentrate, yeah. PRP or BMC.
So PRP, I don't think works. I'm not sure it does anything for anyone anywhere. So, so you're going to use something that has absolutely no proof of its use in CPT. Good luck. I don't see any benefit. I'm sure it doesn't cause any harm, but I don't see any benefit. And what else do you want to use?
Bone marrow concentrate. Bone marrow. Injection of bone marrow.
Yeah, so why do you want to use bone marrow concentrate when you're taking so much cancellous bone that it has about 10,000 times more cells than you can get in all your bone marrow concentrate, right? So it doesn't make sense. So you need the living cancellous bone. I want to make it clear in case anyone misunderstood. No allograft, no demineralized bone matrix. Okay? I mean, if you want to put demineralized bone matrix in the as a bone void filler in the pelvis, I don't care. That's fine. But for the CPT site, no AAA bone, no demineralized bone matrix, no allograft, no calcium phosphate, no calcium sulfate, no hydroxyapatite, no coral. Okay? So look, when you do an operation, do it the way the person who recommended it recommends. Don't modify an operation the first time you do it. Okay? I know that's what makes us orthopedic surgeons. We always modify the operation the first time we do it. But you're not going to, so one thing, you can't get better results than I have. 100% and 0, the best results in the world. Nobody's ever going to get better results. So now your goal is to get as good a result as I have. Okay?
Mm-hmm.
And so why don't you start, and I treat maybe now I treat 20 CPTs a year. Okay, it's a lot. Why don't you probably, those of you who are busy, treat 1 or 2 or 3 in a year. Why don't you start by operating on them exactly with my protocol? Go to the supplement. The supplement shows every step. Don't change anything except maybe the BMP, okay? Mm-hmm. Or except substituting pamidronate for zolidronate because you don't have zolidronate, okay? Except maybe using a rush rod instead of Fessier Duval, okay? Don't change anything unless you want to use a fixator instead of a plate. That's okay. These are reasonable substitutions. but don't start putting all kinds of crap in there. Don't start putting PRP and bone marrow and all of this. And then you fail. And then, of course, the natural reaction is no surgeon ever fails. It must be the technique. The technique failed. Let me tell you, this technique doesn't fail. If you fail, it's you. It's you. You failed. Okay? So this technique doesn't fail. Cross union doesn't fail if you do it right. Okay? It's the surgeon. I remember Professor Lazarev telling me, you know, he liked to say that, I remember him seeing a surgeon who did a Lazarev on an Olier's disease, and it was a terrible, terrible, terrible result. And the surgeon asked him what he thought. And he said, that's my fixator, but it's not my technique. Okay?
Okay.
So that, you know, you might try a cross union, but it's not my technique, then you're going to fail. So do my technique exactly the way I taught it. That's why I published the detail so that people can do it. Read it and read it again and read it again and read it again. And just as you're doing it, follow, have somebody reading it to you so you don't miss any steps. Don't skip steps.
Okay.
If you don't get enough bone graft, okay, then you're not doing the technique. So if you get 10 cc's of bone graft when you need 20, it's not my technique. Okay, it's your failure to harvest enough graft. If you need to, go to the other pelvis. I have cases where I took both sides. You know, this is a harvest of the anterior and posterior iliac crest from an anterior approach. You're getting both, but you're getting it from above the hip. You're literally hollowing out. It's called decancelization of the ilium. You're removing all of that bone. Okay? If you're not getting enough bone, you're going to fail.
Okay. I think last question, how could you ensure removal of all hematoma tissue and not leaving a diseased periosteum? And how can you do this 360 degrees all around?
Go back and look at the drawing.
How you differentiate between diseased and normal periosteum?
You end up removing some normal periosteum. You decide on how long you want the cross union, and this depends on your ability to harvest the bone graft. So if you can get a lot of bone graft like I do, you make a longer cross union. So it is, you know, remove enough, and remove too much, it's okay. So remove too much periosteum. 360 is easy. You have an anterior and posterior exposure, like I showed. Look at the drawings. They show you exactly how to do this.
Can we use Nancy nail or any type of elastic nails? Not
those are garbage. Throw them away.
Okay.
They're the end of the nail is the wrong shape. It needs to be straight.
And put it around Tibia and Fibula?
What?
Okay.
I lost you.
The periosteal graft, you put it around tibia and fibula or just the tibia?
Just the tibia. And honestly, if you said to me, what's the one step you could skip? I think that's the one step you could skip. I don't think it's so important. Yeah, I don't think it's so important. And make sure if you use periosteum, you put the cambium layer down. Don't put the other side down.
Down, you mean facing the bone?
Right. The part that was facing the bone, make sure it's facing the bone. Don't put the part that was the muscle on the bone. Okay?
Yeah. Sure.
I know, sure, but someone will do the opposite.
Yeah, I know. Of course. So, Dr. Bailey, that was really wonderful and great sharing us with your great experience in CPT. I know there was technical issues with this program. We all apologize for that. And also, we promise if you give us next time sharing with another topic, we promise to be in another one, Zoom one, or any other one you are familiar with. And we are completely satisfied that there will be more attendees, because I received many text messages and WhatsApp messages saying that they cannot enter through this application. So again, it is our apologize, and again, we are so happy that you were always within us. Finally, the talk will be to Professor Ismail Yassin. He is the head of our department. He would like to thank you and just conclude the session. Thanks. Dr. Ismail?
Yes, Dr. Ahmed.
Yes. تفضل.
You can. On behalf of orthopedic surgery, Azhar University, I deeply thank Professor Bailey, the well-known landmark, for invitation to share us his great experience. Thanks for his interesting talks that I am sure that everyone has gained. Thanks for Dr. Ahmed Hamouda for organizing this event. And thanks for all our professors and colleagues who joined us. And thanks for Novartis International who sponsor it. Hoping that Professor Berry will be able to share us other webinar, and hoping to see him again on the screen. Thank you, Professor Ahmed and Professor Dr. Berry.
Okay.
Thank you.
Dr. Bailey, you want to conclude?
Well, thank you very much, Dr. Yassin, and thank you for Al-Azhar University for supporting this program, and thank you for all the attendees. I know it's very late where you are. You know, I know it's still the weekend, but I wish you all a good evening, and thank you for staying up so late to listen to this talk. And you feel free to contact me by email or to come to visit us or to come to our course. Be happy to try and advise you or help you on your cases. So
thank you so much. Thank you, Dr.
See you again. Tisbah al-khair to everyone, and ma salama.
Thank you so much, Chef. Thank you.
Okay. Bye-bye.
Bye-bye.